Good evening, everyone. In the previous lecture, we have studied about the normal gait cycle in the broad way. Today, we are going to study the normal foot and ankle patterns of the gait cycle and their deviation at the foot and ankle. So, why this is important? Because the vertical weight-bearing forces from the tibia and talus are transmitted to the horizontal support system, which include the calcaneum, uh, metatarsal, and tarsals. So major joints involved is tibio-talar joint at the ankle, and there are three joints at the foot. That is subtalar joint, mid-tarsal joint, and metatarsophalangeal joint. First, we will study the biomechanics at the tibio-talar joint. So motions happening at this joint are plantar flexion and the dorsiflexion. Arc of motion that used in the walking is 10-degree dorsiflexion to 20-degree plantar flexion. So during the stance phase, this helps in progression and shock absorption. During swing phase, this helps in limb advancement. So there are two alternate cycles of plantar flexion and dorsiflexion. When foot touches the ground, there is first cycle of plantar flexion, then there is dorsiflexion, then there is plantar flexion again, and then in the swing phase, there is dorsiflexion. So there are three cycles of plantar flexion, dorsiflexion, and again plantar flexion that is in stance phase. And there is dorsiflexion in the swing phase. So for initial 12% of the gait cycle, the foot goes into the plantar flexion up to the 7 degrees. Then from 12% to 48% of the gait cycle, there is dorsiflexion up to 10 degrees. From 48 to 62% of the gait cycle, which mark the ends of the stance phase, there is plantar flexion up to 20 degrees. And in the swing phase, that is from 62 to 100% of the gait cycle, there is dorsiflexion to neutral. So the arc is dorsiflexion maximum 10 degree and plantar flexion maximum 20 degree, that is 30-degree arc. Torque acting on the foot. So when foot initially contacts the ground, there is contact at the heel, which is posterior to the ankle joint. So there is force acting on the heel upwards, which creates a plantar flexion torque at the ankle joint, which is in the initial 5% of the gait cycle. Then this weight vector transmits anteriorly to the forefoot. And during this process, it creates a dorsiflexion torque, which occupies the 48% of the gait cycle. Muscles acting during this process are plantar flexors are consistently active during the stance phase. Dorsiflexors are mostly swing phase muscles. Exception is during loading response, they control the rate of the plantar flexion. Main dorsiflexors which are acting are tibialis anterior, which is the main dorsiflexor, extensor digitorum longus, extensor hallucis longus, and peroneus dorsiflex. Extensor hallucis longus is forced to contract and it is active throughout the pre-swing. Plantar flexors, which act during this process are soleus, gastrocnemius, flexor hallucis longus, flexor digitorum longus, peroneus brevis, peroneus longus, and tibialis posterior. Soleus action begins near the end of the loading response, which marks the first dorsiflexion of the foot. There is marked increase in the terminal stance phase and its activity is zero by the end of the pre-swing. Gastrocnemius trend is similar to the soleus. First plantar flexor which gets activated is tibialis posterior. And second is flexor digitorum longus, which get activated at 10% of the gait cycle. And third is flexor hallucis longus, which gets activated at 25% of the gait cycle. Both arc of plantar flexion occurs in the double support period. First plantar flexion occurs at the loading response, which presents a high demand on the pretibial muscles. Why? Within a short period of within a short interval, 60% of the body weight is dropped onto the heel, and the pretibial muscles must respond to decelerate the rate of the ankle plantar flexion. So when the foot initially falls on the ground, there is 60% of the body weight transmits to the heel. So pretibial muscles, which is mostly the tibialis anterior, must act to stabilize the foot and the leg. Second plantar flexion occurs at pre-swing, which is a period of low demand, but the range of motion is greater. First dorsiflexion occurs at the single limb support interval of high demand as soleus and gastrocnemius decelerate rate of the tibia advancement. Second dorsiflexion arc is in the swing phase. So both of the plantar flexion arc is during the double support period, and dorsiflexion arc is in the swing phase or single limb support period. Functional interpretation by the gait phases. In the initial contact, the posture of the ankle is at 90 degree to initiate the heel rocker. So what happens is there is dorsiflexion of the pretibial muscles. If there is weakness in this phase in the dorsiflexion muscle, which causes the 3 to 5 degree drop. Um, Normally, there is the foot is at the 90 degree. If there is drop of about 3 to 5 degree, this will reduce the heel rocker. In the loading response, first arc of plantar flexion occurs. So, heel rocker, there is heel rocker effect. Plantar flexor, there is plantar flexor torque, which causes the plantar flexion of the foot. Pretibial muscles, that mostly the tibialis anterior, will resist this motion and give the stability to the lower limb. So, this decreases the rate of the plantar flexion. The two purposes are served by this. Heel support period is extended, so it will give more shock absorber period. And second is tibia is drawn forward, but tibia is drawn forward at the rate of about half of the plantar flexion. Both actions contribute to the limb progression. During the mid-distance period, when the foot and the heel are both on the support of the ground, there is first arc of the dorsiflexion. At this point, the rocker will be the ankle. Heel and forefoot remains on the ground, but tibia moves forward. Soleus muscle is the main restraint which slows the rate of the tibial control for stability and progression. At the terminal stance, the forefoot is the rocker and the motion will be heel rise. Heel will rise with continued ankle dorsiflexion. Ankle gets locked by the soleus and gastrocnemius. Heel rises as tibia continues to advance. In the pre-swing period, second arc of plantar flexion will happen. So, and there will be knee flexion. Onset of the double limb support, body weight is transferred to the contralateral leg. In the pre-swing period, ankle goes into the plantar flexion till 20 degree, and the magnitude of activity of soleus and gastrocnemius decreases, and this helps in lifting the body upwards. During the initial swing, during the whole swing, there will be dorsiflexion. There will be dorsiflexion of the foot, second arc of the dorsiflexion, which will help in the floor clearance. In the terminal swing support, there will be the neutral ankle will be at the neutral and not dorsiflex. This will prepare the foot for the initial contact. Now we'll look at the joints in the foot. First is subtalar joint. There are two movements at the subtalar joint. One is eversion and inversion. During the stance phase, there is eversion. During terminal stance to pre-swing, there is inversion. And during the swing phase, the ankle remains neutral. Mid-tarsal joint, forefoot. When there is the contact of forefoot on the ground, mid-tarsal joint goes into the dorsiflexion, which will cause the flattening of the arch. When heel rise occurs during the terminal stance, this reverses the dorsiflexion and normal arch is restored. Metatarsophalangeal joint, at the initial contact when heel touches the ground, metatarsophalangeal joint are at the 25-degree dorsiflexion. During mid-distance, they drop to neutral, and during heel rise, there is again 21-degree dorsiflexion at the foot. Muscles which cause inversion and eversion are tibialis. Inversion is caused by tibialis posterior, tibialis anterior, flexor hallucis longus, and soleus. Eversion is caused by peroneus longus, peroneus brevis, extensor digitorum longus, and extensor hallucis longus. So when foot first touches the ground, there the first point of impact is at the lateral calcaneum, which turns the foot towards the which towards the eversion. So this is responded by the inverters, which absorb some of the shock. During this process, calcaneum goes into the external rotation and talus goes into internal rotation, which will create 7-degree valgus at the subtalar joint, and which will cause the internal rotation of the tibia during the loading phase. So during the end of the terminal stance phase, there will be inversion at the subtalar joint, which will be caused by the soleus muscle. Because at this point, soleus muscle is most active. This will lock the subtalar joint. During normal progression, during loading response, first heel comes in the contact with the foot, with the ground. Then at mid stance, heel and forefoot are at the contact with the ground. During terminal stance, most of the forefoot is in the contact with the ground. And during pre-swing, medial side of the forefoot with the great toe is in the contact with the ground. So this was the normal phases that occur at the ankle during the gait cycle. Now we will see the deviations. Ankle gait deviation at the ankle joint, there can be two things: excessive plantar flexion or inadequate dorsiflexion, or excessive dorsiflexion or inadequate plantar flexion. Excessive plantar flexion during stance phase will cause the loss of progression, shortened stride, and decreased velocity. During swing phase, it will obstruct the limb advancement. Compensatory effort will be increased limb or body effort to lift the leg off the ground and advance. So, if there is excessive plantar flexion, this will functionally affect the 5 out of 8 phases of the gait phases. There are 5 phases which involve the dorsiflexion of the foot, which is initial contact, mid stance, terminal stance, and in the swing phase. During the initial contact, if there is excessive plantar flexion, so two things can happen here. There will be low heel contact. So heel will come in the contact with the ground first. When ankle, there is up to 15 degree of the plantar flexion at the ankle, and knee is extended. Heel still initiates the floor contact. If there is forefoot contact, that will be because of there is a mixture of ankle equinus and the knee flexion. During loading response, if there is excessive plantar flexion, it can be of two types. One is flexible. If there is flexible plantar flexion, forefoot first comes in the contact of the ground, then the heel. And if the plantar flexion is rigid, then two things can happen. There will be the person will walk on toes, and there will be excessive knee flexion, or whole foot will come in ground later with when due to the hyperextension of the knee. During mid stance, there is loss of progression. Three compensatory mechanism can happen during mid stance. First is premature heel off. Second is knee hyperextension, so that whole foot can come on ground. Third is forward trunk lean for the balance. During terminal stance, increased heel rise when the during terminal stance there is already heel. Normally there is a heel rise, but foot is in plantar flexion, so there will be increased heel rise when the patient is able to roll on the foot. Body advancement depends on the knee hyperextension or trunk lean and pelvic rotation. Step length will be shortened. Causes of excessive plantar flexion at the foot will be pretibial muscle weakness, plantar flexion contracture, soleus overactivity, or voluntary posturing for weak quadriceps. So, how the contracture or plantar flexion of the foot access the individual phase? If there is 30-degree contracture, so it will mostly the whole gait cycle. When the normally when there is foot touches the ground, there is the foot is in neutral or in slight plantar flexion. So this plantar flexion will not affect the initial contact, but loading response mid stance will be affected, and initial swing and medial swing because uh, foot will be not clear of the ground. If there is elastic contracture, then none of the stance phase will be affected. Only the swing phase will be affected. If there is spastic calf, then initial contact, mid stance, and terminal stance. And most of these phases are when the ankle is in, when there is normally dorsiflexion at the ankle during the gait cycle. If there is pretibial weakness during the, it will affect the initial contact and loading response at as this is the main stabilizer of the lower limb during the initial contact and loading response. And during the swing phase, it is the main dorsiflexor. So this will also be affected. Excessive has more functional significance in stance than swing because normally there is dorsiflexion during the swing phase. Consequently, the heel, consequently, the heel rocker effect on the knee is doubled. There is correspondence increase in the quadriceps demand. During the mid stance, two things can happen. Normally, during mid stance, plantar flexion goes to the dorsiflexion. So there can be increased rate. Plantar flexion will suddenly go to the dorsiflexion, but magnitude of dorsiflexion will be the same. That will be the maximum 10 degree. So final position of the ankle may not exceed the normal 10 degree. And other thing can be magnitude greater than the normal angle being attained between the tibia and the foot, but there will be slow rise. In both situations, uh, there will be increased quadricep demand. During terminal stance, excessive dorsiflexion of the ankle during terminal stance is difficult to identify because there is heel rise and ankle dorsiflexion. These both things will tilt the tibia forward. Cause of excessive dorsiflexion can be soleus weakness, and if the ankle is locked at neutral, or there is knee flexion. Soleus weakness, loss of will cause there will be the loss of tibial stability during weight bearing period. The period at which the ankle goes to the dorsiflexion, and that is the mostly the stance period. Thus, increased demand of the quadriceps. Loss of terminal stance, heel rise. There will be no or slow heel rise and knee extension, which will be replaced by flexion. So, because of both of these things, quadriceps demand will be higher. And the compensatory mechanism for these are there will be the reduction in the heel rocker. As much as the heel rocker, the knee will go into the flexion, and knee is already in flexion. If knee is going into more flexion, this will need more quadriceps action. So there will be less heel rocker and shorter steps and slower walking speed. If ankle is locked at the neutral, that is, if there is pantalar fusion or person is wearing AFO or other orthosis, this will cause excessive dorsiflexion by limiting plantar flexion. Knee will flex and ankle will remain stationary. This will cause increased quadricep demand again. So the ability to tolerate the locked ankle or orthosis depends on the quadriceps strength also. When a person is using sac prosthetic foot, the soft heel is designed to serve as a heel rocker. The transition to forefoot support generates rapid tibial advancement similar to the weak soleus. So, if someone is using sac, he will also need the he will also need more quadriceps strength. So this was about the deviations at the ankle or tibial joint. Now we will look at the deviations at the foot. These deviations can be sagittal plane or coronal plane deviations. Normally, when the foot advances, first there is contact with of the heel. Then lateral border of the heel comes in the contact with the ground, and then the medial border. So deviations are there can be prolonged heel only. Heel there is prolonged contact of the heel throughout the gait phase or stance phase. This can be because of two pathologies. If the forefoot is painful or there is marked imbalance between the ankle dorsiflexors and plantar flexors. There is ankle dorsiflexion and plantar flexors are not able to give the heel rise. There can be premature heel off. So normally this is the period uh, during which the heel comes remains in contact with the ground. Premature heel off can be in the loading response or can be in the mid distance period. Other can be there is delayed heel contact. This will happen when forefoot comes into contact with the foot first, ground first, and then the heel contact comes in contact with the ground. This happens when there is elastic plantar flexion contracture. Prolonged heel only response. Heel is in contact with the ground for the prolonged time, and this will happen when there is absence of the heel rise in the terminal stance, and heel rise will be absent in when there is weakness of the plantar flexion. Curtailed heel only. This means heel only period is shortened due to premature drop of the forefoot. So here heel doesn't come off the ground early. Here the forefoot comes in the contact of the ground early, and this is because of tibialis anterior weakness, and which is also known as slap foot. There can be toe drag. Toe drag is due to failure to adequately lift the foot for swing. In initial swing, toe drag will cause tripping, and limb advancement is delayed. Persistent toe drag into the mid swing tends to significantly shorter the swing phase. So the causes of abnormal floor contact in sagittal pain. Low heel contact. Low heel contact is there when there is plantar flexion up to the 15-degree. This can happen because of plantar flexion contracture, tibialis anterior weakness, or soleus premature action. Period of heel only support is abnormally short. This is when foot flat contact. There is whole foot contact on the ground instead of heel contact first. This is caused by knee flexion rather than the excessive plantar flexion. Knee flexion contracture, overactivity of the hamstring muscles, and dependence on the primitive locomotor control are the main causes. Heel only period is missing in this. So there will be no heel rocker to induce the additional knee flexion. There is already knee flexion. If there is heel rocker, then it will further cause the knee flexion. So heel only period is missing in this. Forefoot contact. We have already seen when there is excessive plantar flexion, there will be the forefoot will contact the foot first. Excessive ankle plantar flexion and knee flexion. Spasticity of hamstring and ankle plantar flexor will cause the forefoot contact. Loading response. During loading response, uh, foot slap happens because of tibialis anterior weakness, delayed heel contacts, delayed heel contact when there is flexible plantar flexion contracture, premature heel rise when there is excessive plantar flexion or excessive knee flexion. During mid distance, what can happen is premature heel rise. This can be due to ankle plantar flexion contracture or excessive knee flexion. During terminal stance or pre-swing, there can be delayed heel rise, which can be due to plantar flexor muscle weakness or knee hyperextension. Now the coronal, we have read about the sagittal plane deviations. Now coronal plane deviations can be excessive eversion and excessive inversion. Normally, we have read that no, there is eversion when first foot comes in the contact with the ground during the loading response. Excessive eversion or varus. In this, floor is contact by the lateral. Oh, sorry. Floor contact by the lateral heel is normal. In excessive inversion, there is also involvement of the lateral foot. So it can be of two types when heel and lateral foot both are in contact with the floor, or only the lateral side of the foot is in contact with the ground. This is in when the inversion is more. Excessive eversion or valgus is when first metatarsal contacting the ground before the fifth metatarsal. Causes of varus, tibialis anterior overactivity. In this, there is swing varus with good ankle dorsiflexion. Tibialis posterior is the source of subtalar varus. Soleus gets active in the terminal swing and through get it is active in during the whole distance, which can cause varus. Causes of dynamic valgus during the stance phase. Total weakness of the inverters. Primary pathology is flaccid or spastic paralysis rather than the excessive peroneal action. Dynamic valgus is not so common in the swing phase. Thank you.
So quite a lot of things covered. Um, did everyone kind of follow in sync with what he was talking? It's pretty much in detail. Then switch off the recording.